Good evening, chairpersons, ladies and gentlemen. At the very outset, I must thank Dr. Chopra, Dr. Parasar, Dr. Rakesh Gupta, Dr. Sashish Gupta, and Dr. Nanda, the whole team for inviting me to speak in this very prestigious conference. Now, we have been talking about vulnerable plaque for more than 2 decades now, but I think this landmark trial by Gregstone et al. Rekindled our interest in vulnerable plaques in recent times. He studied the events and the changes in plaques over 3 years in his stented patients and said that 50% of the events occur in the stented segments and the other 50% occur in the non-stented segment. And this is very aptly shown in this table, that events related to culprit lesions and events unrelated to the non-culprit lesions. And he went on to describe the various features of the plaques which made them vulnerable. These were thin cap fibroatheromas, the minimal luminal area, whether it was less than or more than 4 millimeters square, and what was the plaque burden. What was it, more than 70%, and whether it was less than 70%. And when all the features were present, that made the plaques very, very vulnerable. There has been a paradigm shift from 1996, say, to 2007. In the 90s, we are talking that most ACS occur on less than 50% stenosis. But now with the advent of IVUS, we have understood that most ACS occurs on more than 50% stenosis. But one thing remains, that around 70% of ACS occlusions occurs in angiographically normal areas, because angiogram is a luminogram, and that is very aptly shown in this picture, where A and B are angiographically abnormal, and that is correlated with the IVUS findings. But look at C, it is angiographically normal, but IVUS shows a huge plaque burden. And what are the morphologies or the features of the plaque that make them vulnerable? The increased plaque size, increase in necrotic core, thinness of the fibrous plaque, angiogenesis, which promotes intraplaque hemorrhage, perivascular inflammation, and calcification, particularly in spotty form. Now, these are the various coronary syndromes, as we say, and as you know, atherosclerosis or atherothrombosis is a silent process which takes place over many years. And when vulnerable plaques develop, they are prone to thrombosis, and either they produce acute coronary syndromes, or if the thrombus formation is minor, then it undergoes spontaneous healing, leading to asymptomatic progression of atherosclerosis. Now, these are the various types of changes in the arterial walls. Now, we are talking of fibrous cap atheromatous plaques and thin cap fibroatheromatous plaques, which I am going to tell you. Basically, vulnerable plaques are of 3 types. Number 1 is the thin cap fibroatheroma, seen in 65% of all of them. They have a lipid core more than 40% and a thin fibrous cap. 30% are erosions and 5% are calcific nodules. And these are pictorially shown in this slide, all the features that I have mentioned. And here are the 3 types of vulnerable plaques. The ones thin cap fibroatheromas, the erosion prone vulnerable plaques, and the vulnerable plaques with calcific nodules. And with the combination of OCT and virtual histology IVUS, we can identify these features of the plaques, the confluent necrotic core, the amount of calcification, and the cap thickness. Now, I will show you in the form of pictures, like this combination of IVUS and OCT can define the low-risk plaques or the high-risk plaques, which are fibroatheromas, calcified fibroatheromas, thin cap fibroatheromas, and calcified thin cap fibroatheromas. And these are the various plaque types I have already defined. Now, virtual histology is a special application of IVUS, whereas grayscale IVUS studies only the intensity of the echo or the reflected echo. Virtual histology IVUS studies both the amplitude and the frequency of the reflected acoustic waves, and thereby we get an idea about the composition of the plaques. Now, remember the color codes of these various components of the plaque: fibrous, fibrolipidemic, lipid core, and calcium. Thereby, in unstable angina and MI, we can see plaques with a high proportion of necrotic cores or lipid cores. But in stable angina, we get a higher proportion of fibrous material, making them relatively stable. Now, what is palpography or elastography? This is a special application of IVUS whereby the mechanical properties of the plaque are studied by deformation with interluminal pressure. We get various types of strains, and thereby we identify the high strain spots along the coronary tree which are akin to vulnerable areas. And there is a Rotterdam classification for it. What is OCT? If IVUS studies the reflected acoustic waves, OCT studies the backscattered intensity of the backscattered light. Now, OCT is particularly, important as far as studying of the thickness of the cap, plaque cap is concerned. I am going to show pictures later on. What is thermography? Another modality to study vulnerable plaques. It has a thermistor on a special thermography catheter which studies the temperature of the plaque. And atherosclerosis is an inflammatory disease, and which is shown here that compared to stable angina, unstable angina in MI patients have a raised temperature studied by thermography. This is OCT picture I was talking about. The thin cap of this plaque is very well shown here compared to the thick cap here in a patient with stable angina. And again a calcific nodule in the vulnerable plaque, very well shown with the OCT. Now, compared to coronary angioscopy and IVUS, OCT is best designed to study the thickness of the plaque cap. But as far as thrombus detection is concerned, angiography is definitely superior to both OCT and IVUS. Now, here again we can show the thickness of the plaque very well with OCT here. Now, near infrared spectroscopy or NIRS is another modality to study the vulnerable plaque. Now, it studies the molecular vibrational transitions in the NIR region, thereby giving us an idea about the chemical composition of the plaque, which correlates very well, as shown in this slide, with the histology findings. Now, we come to the modality that is most available to us, MSCT. Now, it can also study the character of the plaques and tell us which plaque is vulnerable and which is not. It studies the radio intensity, how much Hounsfield unit, the positive remodeling, and spotty calcifications. And if all these features are present, that makes a plaque more vulnerable than others on the MSCT findings. And if all three are absent, that makes a plaque less likely to be vulnerable. Now, here are the pictures which shows a vulnerable plaque, positive remodeling, less than 30 Hounsfield units, and presence of spotty calcification. Compare this with a person with positive stress test, but with a stable plaque, negative remodeling, Hounsfield unit more than 150. And here again we can see a relatively stable plaque with lot of calcification and quite radio intense, more than 150 Hounsfield unit. And vulnerability on MSCT has a relationship with calcium score. Now, from 0 to 500, there is a positive relation, a linear relation between presence of vulnerable plaque and coronary artery calcium score. But beyond 500, there is no such relation between vulnerability and calcium score. And again, CT verified vulnerable plaque has a close relationship with the Framingham risk scoring also, as shown in this slide. Now, there are articles galore in recent journals on the identification of vulnerable plaques with MSCT, and ring length enhancement on MDCT is another feature that has been described recently as far as identification of vulnerability is concerned. And these ring-like enhancements are very well correlated with OCT findings also. Now, napkin ring necrotic course is another feature that has been described in recent times, defining circumferential extent of necrotic course in unstable plaques. And low attenuation plaque volume and area are other features that have been described as far as identification of vulnerability is concerned. Now, what is the vulnerable plaque hypothesis? Where are we? This is a brilliant article by Steve Nissen in JACC Imaging Journal, and he said that it is assumed but not proven that presence of large number of TCFAs represent a harbinger of future vascular events. But just having a TCFA, does it mean that prognosis in this particular patient is very green? May not be. A plaque with 9% necrotic core and cap thickness of 66 micron would be a high-risk lesion. Such arbitrary rules make little biologic sense. Plaque instability is distinctly multifocal phenomena, hence a multitude of such high-risk lesions are likely present. Even if we accept TCFA as a true vulnerable lesion, we would need to find and map all the TCFAs. That is, it will need a very invasive scanning of all the three coronary arteries with guide wires. And if a plaque is high risk today, does it mean that in coming weeks or months it will continue to be high risk? Can we assure that a plaque classified as stable will not undergo acute conversion to a vulnerable lesion within few weeks? We must understand that atherosclerosis is a systemic disease, and hence agents like statins, antiplatelet agents, smoking cessation, etc. would be more applicable for our vulnerable patients than identifying vulnerable plaques alone. Because at the center of our attraction is the vulnerable patient. For him, vulnerable plaque is definitely important, but equally important or more important is the presence of vulnerable blood and vulnerable myocardium. So if plaque imaging as it stands today is to emerge as a major imaging modality, then it should overtake Framingham risk score, CRP, coronary calcium score and all that. The imaging must also have a high positive predictive accuracy so that individual rupture-prone lesions can be timely treated. We are all looking forward to this trial security, which should answer some of these questions. One must recognize that we are still far from the mark. Thank you very much for your patient hearing.
Thank you very much. I definitely agree that there may be a lot of questions for all the three speakers, but for want of time we have to conclude. All the three speakers did very well, and they were all high-profile talks, highly technical oriented and very useful also, particularly the extracorporeal ultrasound. So all the three speakers did very well. I thank them profusely for their very, very educative, informative lecture. Thank you.
Ladies and gentlemen, may I invite Dr. A.K. Umar, our chairman, to please step forward and present a medallion and a citation to Dr. Chetan Shah, our first guest lecturer. Dr. Shah, if you could please step forward and kindly accept this honor that's been conferred on you for having delivered this guest lecture. I would now like to invite Dr. Hala L. Marsafavi to kindly honor Professor AAS Majumdar from Bangladesh. I would now like to invite Professor Muralidhar Rao to please step forward and present a medallion and a citation to Dr. Soumitra Kumar. Thank you very much, gentlemen. That brings us to the end of the academic deliberations of day 2. Before we conclude, here's an important piece of information from the organizing chairman, Dr. H.K. Chopra. Dr. Chopra, please.